upward displacement of the fetal head from below, relaxation of the uterine muscle. I think it is important to use these, glyceride trinitrite spray sublingually, and also a head down tilt. It helps you enormously actually to disimpact the baby's head and deliver it more safely without much extensions, etc. Okay. Cochrane says that breech delivery compared to vaginal disimpaction is associated with less maternal bleeding, but again, it depends on the operator's experience. Whatever then technique, it is mainly shoulders which are delivered first, and then the trunk, breech, etc. And the last one is the head to be delivered. Whether it improves the maternal outcomes, we don't have big studies. Fetal pillow, yeah, that is, it can be, it is inserted through the vagina and against the fetal head, and it is inflated with saline in an attempt to elevate the fetal head. Again, yeah, the question, I mean, well, comparative studies, difficult again. And also, snorkel, it is a suction-like tube. It can be inserted between the vaginal wall and fetal head, and aeration through the ports can alleviate the vacuum between them, aiming to lessen the force required to disimpact the fetal head. So if you had a deeply engaged head, use a step or a stool. Ensure the table is tilted in Trendelenburg. Wait for the contraction to cease or give some uterine relaxant, and push the fetal head upwards, flex and deliver. But be careful, once the fetal head is disimpacted, it can be displaced superiorly, it can disappear from your hands. So maintain longitudinal line, apply firm pressure, deliver the fetal head with forceps, etc. Now, these are the problems, yeah, pitfalls, and how to manage the pitfalls I have talked about with instrumental delivery, section, etc., etc. It's quite a monotonous thing that I have spoken to you about. But I would like to just say there are many pitfalls in the CTG interpretation which can increase the section rates or instrumental delivery rates. So failure to interpret fetal rate, fetal trace correctly during second stage of labor is very common. So increased maternal and neonatal morbidity due to unnecessary cesarean sections or instrumental deliveries, and delay in timely or appropriate intervention can also be a problem. So poor signal quality, because if the mother has been pushing and in pain all over the place, it is very difficult to monitor, and inadvertent maternal heart rate monitoring can happen, giving you false assurance that everything is all right. Or it can be other way also. You can think that there are significant decelerations and rush in for section or instrumental delivery, causing more trouble. So important to understand that with head compression, there can be early decelerations, and decelerations are not an indication to just jump in and do a section or instrumental delivery in second stage. What is important is recurrent late decelerations where the baby is failing to come back to the baseline, the FHR is failing to come back to the baseline, or prolonged decelerations repeatedly increasing, have been happening, or in all of a sudden there is a saltatory pattern which is persisting. So all these should be taken with caution and should be acted upon. So if you can see this, we still can achieve vaginal delivery. There are some overcontractions here, but it is coming back to the baseline. She is nearly there. It is, head is visible. So you can wait. You don't have to rush in and do a vaginal delivery. So here there was a nosedive, but before that the baby was all right, and now it has come back. It is taking time. Maybe the baby is getting tired. Maybe you will have to intervene if it is remaining like this. But fortunately, by the time we got ready for a forceps delivery here, it has started recovering. So you can wait. Nevertheless, make sure that the baby is not, not diving again and again, there are no further episodes of bradycardia. And appearance of fresh meconium in second stage with such a trace might be an indication for expedite delivery. So second stage, again, we talked about giving time, but how long is too long? With every hour, the postpartum hemorrhage can increase, especially after 2 to 3 hours. Before that, if this is the baseline, nearly 6% of women can have postpartum hemorrhage, even if it is less than. Plus, addition of these, you have to be aware of. Okay, blood transfusion, obstetric trauma, especially third and fourth degree tears, can increase, and also risk of chorioamnionitis can increase. These are yellow, the figures depicted in yellow are beyond the background risk. So, the impact of extending second stage of labor to prevent primary section on maternal and neonatal outcomes, the new policy definitely has reduced primary cesarean deliveries, which is very important, with a small rise in instrumental delivery. But umbilical cord pH was most significant, finding that if the babies born had slightly lower umbilical artery cord pH, but the early neurological outcomes did not change. So we need long-term studies for the 3+1. So I don't want to due to paucity of time, I don't want to go into the details, but what all studies say is maybe there is a small increase in fetal acidosis with increasing duration of second stage. And also the third and fourth degree perineal tears can increase with instrumental delivery, especially with prolonged second stage. So in conclusion, I would like to say women are designed to deliver vaginally unless otherwise indicated. So we should not go against nature without a strong medical indication. Good obstetric practice, you will have second stage dilemma. They are inevitable. Allowing 1 to 2 hours of passive second stage for descent of fetal head is important. Allowing pushing for 2 hours in nullip and 1 hour in multip, I think it is very important. Of course, in our country, lay women might get exhausted sooner than later. That's what we say. But in our setup, we have kept our nullip section rate down to less than 15%. I'm very proud to say that. And they do push. They should be taught yoga. They should know how to relax. They should know how to push. All these are very important. We can't just say Indian women are weak or they are not so strong to push for 2 hours. Unique protocols are important. Involvement of senior OBGYN is important. Accurate abdominal vaginal examination is the key for mode and place of delivery, because if you want to say that this lady is suitable for instrumental delivery, you have to decide where she has to be delivered. Don't jump and do sections unnecessarily. Practicing the art of instrumental deliveries, you need skills and drills to train our juniors and also ourselves. Second stage CPG interpretation, training and teaching are very important. Senior OBGYNs to pass on the tips and tricks. Be cautious, but be bold. Do not overdo, but do not underplay. Do not be overconfident. Learn to be humble. Learn to respect nature. You should know how to do, when to stop, what to do, even if you got into trouble. Second stage management calls for fine judgment of the obstetrician to do the best for the mother and progeny, both short-term and long-term. So if you want to cross the road, you should know when to stop and when you can safely cross the road. But don't stop crossing the road. Thank you very much for your patient hearing. Thank you. I would have loved to see all your beautiful faces, but unfortunately, that's the limitation of the web. Thank you.
Thank you, Dr. Lata. It was a wonderful talk, I should say. And like you said, we should allow every woman to realize their fullest potential to have a vaginal delivery. And of course, another important thing you have stressed is how it is vaginal delivery is important not only for the mother, but also for the future well-being of the progeny. That was very well this thing. And of course, rethinking the duration of the second stage. I think that's also very important. And of course, we have to individualize the management. And the how your tips and tricks, how to do a second stage cesarean in case the vaginal delivery doesn't happen. I think that there are a lot of useful points we could pick up, and also the CTG interpretation in the second stage. Sometimes we are at a loss. So that also was very useful to all of us. So I think finally, like you said, a pragmatic approach is very important when we are dealing with second stage of labor. And hopefully we'll have more and more women delivering vaginally only rather than this high cesarean section rates which we have right now. And of course, now the buzzword is respectful maternal care, where like you said, birth attendants and communication and all this is very important. I think now we have a few questions, and one is from Dr. Ganesh. How does maternal position affect the second stage in mothers with epidural analgesia?
Sorry, can you come again, please? So how does mother's decision?
Yeah, how does maternal position affect the second stage in mothers with epidural analgesia?
Yes, maternal position is still very important because the descent, if it has to happen, you have to have a conducive position, and it should not be just, the perineum should not be just be compressed. Okay, so upright positions or squatting positions will allow the pelvic diameters to open up and the head to come down. These positions might not be possible with epidural analgesia. That is the problem. So you want them to be in lateral position. Some of the midwives are very, what can I say, who are well versed in second stage, they even just sort of fold the leg up, flex and fold the leg up so that it opens up the pelvis, and also ask them to sort of bear down. And if it is, some of them, I mean, there is no scientific evidence, but for example, if the baby is in LOP, they put them on the right lateral position and then hold their leg up, ask them to bear down so that the head turns in the opposite direction, either to OA or to direct OP. So things like this. So, and pelvic muscles are fairly relaxed, levator ani especially, so it doesn't sort of, I mean, well, so it should, for the head rotation to take place, the levator tone is very important. That might not happen with epidural analgesia if it is dense.
Yes, thank you. And one more, I think already I've answered it. Dr. Vidya is asking, what maternal position would you prefer in parturients during bearing down? I think already I've answered that. Would you like to add anything more?
Yeah, I want to talk about some yogic positions. Actually, Baddha Konasana, that is the butterfly exercise. Yeah, and if the lady can squat with the feet put together and the thighs in this position, and if she bends forward, it presses against the cervix, and also the head aligns more easily to the pelvic curvature. And we have found that the second stage of labor is shorter, and also expensive efforts that a mother needs to put in to push the baby are less, because it would have descended quite a bit. So we encourage them to do this Baddha Konasana throughout labor, even during second stage.
So all your patients, do you tell them you do yoga, and so that do you start the antenatal classes and include yoga in it?
Yes. Yeah, so and also we encourage them to do what is called as instant relaxation technique between the contractions, where they the breathing is slowed down. They pick up energy to push and count to 10. That is, with the breath, you just ask them to take a deep breath and you're going to count to 10 and they keep pushing with the clenched teeth and chin on their chest. It's very important. Yeah.
I think that's a very
boom.
important thing. I think many obstetricians would like to incorporate yoga also as part of the antenatal exercises and preparations for childbirth. I think those are the questions. I think it was a wonderful session, Dr. Lata. Thank you from all of us.
Thank you.
I would like to thank, on behalf of our organizing committee, I'd like to thank Madam.
Thank you.
For such a wonderful talk and giving tips on what we should do during or what we should not do during second stage of labor. Thank you very much.
Thank you very much. I thoroughly enjoyed. Yeah. Thank you again. Yeah.
And I welcome our next speaker, Dr. Sally Abram. Over to you, Madam Vatsala Kamath.
So the next talk is active management of the third stage of labor. This is by Dr. Sally Abraham. She is the professor and HOD, Department of OBG, Enapaya Medical College and Hospital, Mangalore. She has been the recipient of the Dr. Subbalakshmi Award for standing first in the university in the DGO examination. She has worked as a senior specialist in the Kingdom of Saudi Arabia for 7 years. She was awarded Best Doctor Award by Enapaya University in 2019. She has been the past Vice President of Mangalore Obstetrics and Gynecological Society. She is a reviewer of BMJ case reports. Her areas of interest include high-risk obstetrics and preventive gynec oncology. Over to you, Dr. Sally.
Thank you, Dr. Vatsala, for that warm introduction. I bring greetings from Enapaya Medical College, Mangalore. At the outset, I would like to congratulate Team KVG Sullia for this excellent National E-Conference on a topic that is very important to all practicing obstetricians. I quote Jeffcott, "Labor can be the most dangerous journey a human ever undertakes." Very true statement. An uneventful first and second stage can become abnormal within a minute with disastrous consequences. A woman can lose her entire blood volume due to postpartum hemorrhage in just 7 minutes. So the third stage of labor is a very important period. It's the time between the birth of the baby and the delivery of the placenta and membranes. The most perilous for the parturient woman because of the risk of PPH. The average duration of third stage of labor is 5 to 15 minutes. Third stage is considered prolonged if the placenta fails to separate within 30 minutes after childbirth. A third stage longer than 18 minutes is associated with a significant risk of PPH. And there is a 6-fold increase in postpartum hemorrhage when the third stage of labor lasts longer than 30 minutes. So active management of the third stage of labor prevents up to 60% of postpartum hemorrhage. The principles of active management of the third stage of labor is to execute powerful uterine contractions within 1 minute of delivery of baby by parenteral oxytocin. It enhances the separation of placenta and ensures safe and complete delivery of placenta and effective uterine contractions, thus minimizing postpartum hemorrhage. Advantages of active management third stage labor, again, minimizes not only third stage bleeding, but also postpartum hemorrhage by 60%, shortens the duration of third stage by half, reduces the need for blood transfusion, and reduces the incidence of maternal anemia. What are the disadvantages of active management of third stage labor? There is a slight increase of retained placenta of 1 to 2% and consequent increased incidence of manual removal of placenta. Now, the WHO recommendation for active management of third stage of labor 2012. Administer an uterotonic within 1 minute of delivery of the baby after having ruled out twins. The drug of choice is oxytocin. Oxytocin 10 units IM Or if IV access is in place,
Hello.
10 to 20, yes. Can I proceed?
Yeah, you can proceed.
Yes, ma'am. Sorry.
If IV access is in place, 10 to 20 units oxytocin and 500 to 1000 ml at 60 drops per minute for 15 minutes, followed by 40 drops per minute. Oxytocin is safe, effective, cheap, stable at 15 to 25 degrees centigrade, and has no contraindications and can be used in all patients. In low resource settings and in the absence of skilled birth attendants, tablet misoprostol 600 micrograms oral or per rectal can be used. The other options are injection ergometrin and symptometrin. Now, these other options are not the preferred. I still repeat that oxytocin is the recommended and the most preferred oxytocins. Now, if you want to give ergometrin, it is 0.2 milligram IM if there are no contraindications. Contraindications being cardiac disease, hypertensive disorders, occlusive venous disorders, renal and hepatic impairment, sepsis. Or symptometrin, which is a combination of ergometrin 0.5 milligram with 5 units oxytocin given IM. Now the symptometrin has the same contraindications as ergometrin. Cord cutting. Clamp and cut the cord after cord pulsations have ceased or 1 to 3 minutes after birth of baby, whichever is earlier. Now, the cord pulsations usually cease within 1 minute. It is official that you should delay the cord clamping unless there are some indications for early cord clamping, like the baby needs resuscitation, a preterm baby that requires that you need to clamp the cord early to prevent hypovolemia and hyperbilirubinemia, and RH incompatible pregnancy, and HIV positive mother. Giving oxytocin before cord clamping has no known harmful effects. Now, how do you clamp and cut the cord? You can clamp the cord 5 centimeters from the umbilicus, but before you do that, you squeeze or milk the cord. This is to make sure that that there is no accidental inclusion of embryonic structures, embryonic remnants in the extra embryonic coelom. Now, if you go to the early embryology, the intra-embryonic coelom is continuous with the extra-embryonic coelom along with herniation of coils of the midgut. So now if the conditions persist, if you do, you might accidentally include the embryonic remnants. That's why we advocate squeezing or milking the cord before we actually clamp, and you cut the cord between 2 clamps and use a gauze piece in between so that there is no spurt of blood. Now, giving oxytocin before cord clamping has no harmful effects. Control cord traction. Control cord traction, we do this, most of us know it, but for completion's sake, support the uterus. You hold if you're a right-handed person, hold the cord that is clamped closer to the perineal end of the mother. Hold it with your dominant hand, the right hand, and with the left hand is placed on the suprapubic region. And when there is a contraction, apply pressure of your abdominal hand in an upward direction towards the patient's head. At the same time, your right hand applies firm, steady traction on the cord in a downward direction, in the direction of the birth canal. Your downward traction should be steady and gentle and not a jerky or a forceful pull. Controlled cord traction should only be performed during a contraction and by a skilled birth attendant. Now, this is an important point, that it should be done along with during a contraction and by a skilled birth attendant. Immediate fundal pressure, massage is optional in the 2012 WHO recommendation. This is because sustained uterine massage is recommended as an intervention to prevent PPH in a patient who has received, is not recommended as an intervention in a patient who has already received prophylactic oxytocin. But there is no hard and fast rule. You can give fundal massage. This is optional. But postpartum abdominal uterine tonus should be assessed for early identification of uterine atony. Every 15 minutes, you must do it for the next 2 hours. Examination of the birth canal and the afterbirth. So look at the placenta for missing cotyledons and the completeness of the placenta and membranes. Meanwhile, inspect the birth canal for any vaginal tears or lacerations, cervical tears, and repair the episiotomy. Careful monitoring of the patient and her newborn for at least 2 hours postpartum. Now, the scheme of management of third stage of labor, and the next slide is going to compare between the expectant management and the active management that we now follow. In the expectant management, we deliver the baby, and after which the clamp is cut and ligated. The time of cord clamping could be variable, may or may not be clamped early. But in our active management, we gave oxytocin 10 units IM, which is the preferred 1 minute after the delivery of the baby or at the delivery of the anterior shoulder. We delay the cord clamping till the cord pulsations have ceased, or approximately 1 to 3 minutes after the birth of the baby, whichever is earlier. Now, in the expectant management, after the cord clamp, we wait for spontaneous separation of placenta, looking for the signs of separation of placenta, that is fresh onset of bleeding, extravulval lengthening of cord, suprapubic bulge, and fresh onset of contractions, and wait for the spontaneous expulsion by gravity and maternal effort. Well, while in the active management of third stage of labor, we deliver the placenta by controlled cord traction, availing the first uterine contractions after the delivery of baby. If that fails, wait for 2 to 3 minutes, repeat the controlled cord traction. If it again fails, wait for another 10 minutes and repeat the controlled cord traction. If you again fail to deliver the placenta, you will have to do a manual removal of placenta under general anesthesia. Now, in the expectant line of management, if you fail to deliver, if the placenta fails to deliver, you have to do a manual removal of placenta. And the examination of placenta, membranes, and the vulva, vagina, and the perineum has to be done after it has been, the placenta and membranes have been delivered. Now, what are the uterotonics that we use? Oxytocin is the uterotonic of choice for active management of third stage of labor. It's a synthetic oxytocin identical to that produced by the posterior pituitary. Onset of action within a minute, mean half-life 3 to 5 minutes, duration of action is 20 minutes. Oxytocin is safe with no contraindications. It is cheap and effective. It is less heat labile. It can be stored at 15 to 25 degrees centigrade. Water intoxication with high doses of oxytocin because of the antidiuretic action is seen if administered in large doses and if large volumes of electrolyte-free solution like dextrose is used. Misoprostol is another uterotonic. It's a prostaglandin even analog. It is cheap, it's stable at room temperature. It is oral route or upper rectal route. Oral, you have a sustained absorption. It can also be used sublingual. There is increased access at the community level, and in deliveries conducted at low resource settings, not attended by a skilled birth attendant because of ease of administration. The side effects being shivering, fever, nausea, vomiting, and diarrhea. Ergometrin, the other alternative, is cheap, effective, heat labile. It has to be stored at 2 to 8 degrees centigrade away from sunlight. Dose is 0.2 milligram IM. IV we do not use unless for some, in cases of postpartum hemorrhage. Taking to mind the contraindications for ergometrin: onset of action 7 minutes IM, duration of action 1 hour, contraindications: cardiac disease, hypertensive disorders, occlusive vascular disease, hepatic renal dysfunction, sepsis. Side effects: nausea, vomiting, headache. Most dangerous one, the blood pressure shoots. The diastolic blood pressure may go more than 100 millimeters of mercury, and this will be harmful for those who are already hypertensive. Ergometrin should not be used in the absence of controlled cord traction because of the risk of retained placenta associated with tonic-clonic contractions induced by ergometrin. Symptometrin, each ampule contains synthetic oxytocin 5 international units per ml and ergometrin maleate 0.5 milligram per ml. Advantage of symptometrin is that combines the rapid uterine action of oxytocin with the sustained oxytocic action of ergometrin. Dose is 1 ml, that is 1 ampule given intramuscular for active management, third stage labor. Onset of action within 2.5 minutes. Duration of action 3 hours. Contraindication same as ergometrin. We have a new drug, carbetocin, a synthetic long-acting oxytocin derivative, 1-diamino-1 monocarbo 2-0 methyl-thyroxine oxytocin. First described in 1987. The dose is 100 microgram IV, bolus over 1 minute. Onset of action less than 2 minutes. Duration of action is 12 to 16 hours. It's heat stable at 30 degrees centigrade and 75% humidity, and it maintains its efficacy at this temperature and humidity for 3 years. Its safety profile of carbetocin is as good or even better than oxytocin, with hardly any antidiuretic effect. It has a good hemodynamic profile. That is, there is no the blood pressure remains unchanged. While with oxytocin, if you give a slow direct IV oxytocin, you may have hypotension and tachycardia. Therefore, we do not advocate direct IV. With carbetocin, this is not seen. Therefore, we say it has a good hemodynamic profile. A single injection is more effective than continuous infusion of oxytocin to maintain adequate uterine tone. It is licensed in the United Kingdom specifically for the prevention of PPH in C-section. In fact, there was a randomized control trial involving 30,000 women in 10 countries, including India. In India, I'm told 6 centers were identified for this RCT trial, wherein they have tried this drug for to prevent PPH in C-sections, because its action is also lasts for 12 to 16 hours. But the disadvantage is it's expensive and it's not yet available in the Indian market. It was supposed to have come out in the Indian market in December 2019 or early 2020, but because of all our prevailing situation right now, it is not yet available in the Indian market. So carbetocin is a very promising drug for us. Now, there's something like skin-to-skin contact, which is also encouraged in the active management of third stage of labor, though it doesn't actually come under the 3 headings. So here the baby is directly placed on the mother's abdomen or chest right after birth, provided you have assessed the baby and the baby is breathing and Apgar score is good and does not require any kind of resuscitation. The baby has skin to skin contact with mother. All that you need to put is a bonnet on the baby's head, cover baby and mother together with a blanket. Now, the benefits of skin to skin contacts are both for the mother as well as to the baby. The benefits to the mother would be more release of oxytocin, which helps in the contraction of uterus in the third stage of labor. It also releases beta endorphins that work like a mild analgesics and makes the mother feel calmer and relieved. Benefits for the newborn: it provides warmth and helps maintain newborn's body temperature. We know that this is a problem in the newborn, and therefore the skin-to-skin contact helps maintain newborn body temperature, same as the kangaroo care. Now, it also makes it easier to breastfeed the baby, as the baby naturally crawls towards the mother's breast, and the latch on is easier, babies nurse longer, the baby's heart rate, blood pressure and sugar levels are maintained within the normal limits. Extra benefits for the preterm baby is improved neurological development, better and faster growth, shorter stay in NICU. Of course, a preterm baby may not be advisable to do a skin-to-skin contact immediately after birth, because baby may have problems, may have to be resuscitated, but early skin-to-skin care, the kangaroo care, is based on this. Now, a little bit more about cord clamping. Keep the baby at or below the level of the placenta. Let's gravity help flow the blood from placenta to the baby. Delay in clamping and cutting the cord allows an additional of 40 to 80 ml of blood to the baby, and this provides an extra 30 to 35 milligrams of iron and thus prevents anemia, at least for the first 3 months. Early cord clamping is done in cases where babies require resuscitation, preterm, babies of HIV mothers, positive mothers, average incompatible pregnancies. Delayed cord clamping is the official way to go when and where possible. Now, this is a picture which shows the delayed cord clamping and how the umbilical cord pulsation cease because of spasm of the umbilical artery, reducing the flow to the placenta. I would like to conclude by saying active management third stage of labor is a simple, safe, cost-effective methods of preventing PPH, and we should initiate national policies that continue to promote active management third stage labor and ensure that systems are in place to monitor and track its implementations. Policies should support the practice of AMTSL in all maternity facilities by all cadres with midwifery skills. Policies should ensure availability of high quality oxytocin and encourage storage of oxytocin in cool environment. So the cold chain should be maintained. It can be maintained at 15 to 25 degrees centigrade and can be kept at our temperature for a couple of hours in the labor room. The hand that rocks the cradle rules the world. It's so very true. So it is our duty as obstetricians to ensure that the mother gets optimum care all throughout, not only her pregnancy and labor, but we manage the third stage of the labor by following the methods of active management of third stage, and thus reduce the incidence of postpartum hemorrhage. Thank you for your patient hearing, and I thank KVG Sulya for this opportunity.
Thank you, Dr. Sally, for an excellent presentation on the active management of third stage of labor, and also about the various oxytocics you spoke about and delayed cord clamping. as you correctly pointed out at the end, one of the cornerstones of AMTSL is actually oxytocin, other than the other two, see the control cord clamping and uterine massage. But the most important thing is the oxytocin. And you, like you said, how are we keeping it in the 80s? Because I think somebody has to, it will be left outside and the cold chain should be maintained. But for a short periods of time, like you said, it can be kept outside and it maintains its potency. But if you neglect to keep an eye on the oxytocin, I think the potency might go. I think that's a very important point. And the other point, I think for the sake of postgraduates, can you tell, now the baby is delivered and now usually what we do, what is the importance of waiting for the natural, the signs of placental separation, or do they just go and pull on the cord? That's very important because I've seen it happening.
Yeah, we are.
What do you say?
Yeah, we are expected to follow the active management third stage of labor. So with the coinciding with the first uterine contractions, we should follow the control cord traction or the Brand-Andrews technique. So when you do the cord traction and you find that the placenta is not being delivered, undue force should not be applied. So you wait another 2 or 3 minutes and try again with the next uterine contractions. And again, it doesn't, there are no signs of separations. Then you wait another total of 10 minutes in toto before you try, make the last and final try. And then if that too fails, then only the manual removal of placenta is advocated. Now the incidence of MRP with the active management of third stage of labor is very minimal, just 1 to 2%. That is why we prefer oxytocin rather than giving ergometrin.
Yeah. All right. I think that clarifies the point. Then any other questions? I think one question.
Yes, ma'am, we have
What
questions.
is the incidence of retained placenta in your practice, madam? By Dr. Ravikant.
Yeah, the incidence of retained placenta, I think in Yanapaya is something like less than 1%, I would put it.
All right. Then Dr. Nagma Sheikh is saying, early or delayed cord clamping in COVID mothers, since perinatal transmission is common these days.
Yeah, a very good question in this scenario. COVID positive mothers, we have handled a good number of COVID positive deliveries, and there is no particular advantage to the baby with an early cord clamping. It is just that you should not encourage skin to skin contact, but because the vertical transmission is not proved yet. And what we find is most of the time it is due to the aerosol and skin to skin contact. So the mother is also encouraged to nurse the baby by following the protocols of mask, hand hygiene. And when she is not nursing her baby, the baby is kept at a distance of 6 feet with another attendant, relative nearby. Or in a cradle that is kept 6 feet away. So as such, early cord clamping does not prevent the baby from acquiring the COVID infection.
Yes, I think that's very clear from what you said. One more question is from Dr. Ravikant again. What's the role delayed cord clamping in preterm fetus? In delayed cord clamping, what's the maximum time that can be allowed? I think you're told about it, but I think you can again answer if you don't mind.
Yeah.
One is what's the role of cord clamping in preterm fetus?
Delayed cord clamping, how long you wait? You wait till the cord pulsation ceases. Normally, usually it ceases within a minute. So the maximum you wait is about 2 or 3 minutes. Either the cord pulsation ceases or it is 1 to 3 minutes after the delivery of baby. But usually the cord pulsation ceases within 1 minute. And in a preterm baby, you would go in for an early cord clamping, because most of the time it requires, babies require resuscitative measures, or even if it doesn't require resuscitation, we don't want this extra 40 or 80 ml to load for fear of hypovolemia and hyperbilirubinemia, which is more common in the newborn, in the preterm babies.
All right. And the second part of the question was, in delayed cord clamping, what's the maximum time that can be allowed? I think that you've already spoken then. And somebody on Dr. Praveen has told, delayed cord clamping can be done in preterm babies also, according to the new AIIMS guidelines, ma'am. That's what it is.
Yeah, I have to look it up. As far as I know, these are the reasons why we go in for early cord clamping and don't delay cord clamping in a preterm baby.
That's our general understanding, that we don't delay, means try to clamp early so as to, in case they require resuscitation. I think that's all the questions, and I think the session has been wonderful.
Yes, we have just a minute, ma'am. We have Lata madam online. Ma'am, can you give your inputs on active management of third stage of labor? Your experience about management of third stage of labor. Dr. Lata Venkatram. Madam. I think, okay. Thank you very much, ma'am. Thank you, Dr. Saleh Abram, ma'am, for giving such a wonderful talk on active management of third stage of labor and giving an overview of all the uterotonic drugs which we can use for the active management of third stage of labor. Thank you, madam. And I would also like to thank Dr. Vatsala Kamath, madam, for chairing the session and giving your inputs, ma'am.
And I would also like to thank all the wonderful speakers and the very enthusiastic audience, I should say, and of course the organizers from KVG Sulia for this conference, which is actually need of the hour, I should say, where we have to focus on the basics in obstetrics and how more we can have more vaginal deliveries, and labor and vaginal birth, I think it's the most important topic of the day. So thank you one and all. And thank you the organizers.
Thank you very much.
Thank you so much, Dr. Vatsala ma'am. And I would also like to thank all the speakers and our coordinator, Dr. Bhavya, for this illuminative session that we've had. Now we would break for lunch, and let me remind you that we begin at sharp 2 p.m. and we will be having a special speaker lined up, Dr. Parag Biniwale, Honorary Secretary ICOG, talking on a very important topic, especially for the postgraduates, on induction of labor. So stay tuned and see you at 2 p.m. sharp. Thank you.